Colleagues, now that we've talked about measurement-based care, well, let's focus now on the goals of treatment, which have to do with things like remission and functional recovery, but also, and this is a major point, on the prevention of relapse and recurrence in older adults with major depression. I like to say to my patients, getting well is important, but it's not enough. Staying well is also important. The goal of treating clinical depression in older adults, a better life, and hopefully also a longer life. We're interested in achieving symptomatic remission. We want to promote functional recovery because that matters a great deal to both patients and their family caregivers. We want to prevent relapse and recurrence and the evolution of a chronic, more treatment refractory form of depression. We are interested in attenuating, delaying, or preventing the downstream consequences of depression, including dementia, and we hope, obviously, to prevent suicide. We also want to reduce caregiver burden. My philosophy is that the treatment of depression in older adults should be both patient-focused, but also family-centered. Finally, and very importantly, we want to facilitate the appropriate use of general medical and social casework services. Another way of saying this is that depression in older adults rarely occurs in pure culture. It is almost always associated with co-occurring medical and psychosocial problems. Team-based approaches to treatment enable the co-occurring medical and social problems to be addressed by colleagues with appropriate domain-specific expertise. So why do we care about remission of symptoms? Not just response, but remission of symptoms, which, as I mentioned before, is generally indicated by a PHQ-9 score of less than 5 and hopefully close to 0. Well, remission of symptoms is the first goal from my clinician's perspective of treating major depression in older adults because response without full symptomatic remission continues to be associated with disabling symptoms, with suffering, with functional impairment, and with a higher risk for relapse and recurrence, as well as for inappropriate healthcare utilization. There is also, in connection with my dictum of taking a long-term perspective on the treatment of depression in older adults, long-term treatment is necessary to prevent relapse and recurrence because very often depression in older adults is subject to high rates of relapse and recurrence. Looking at this from a neuroscience perspective, there is abundant evidence that treatment may promote brain health and possibly reduce the risk for dementia. The jury is still all out on that question, but I think it's reasonable to suggest that as a hypothesis. Finally, and this is of particular interest, I think, there is some evidence that appropriate treatment of depression in older adults may actually enhance not only the quality of life, but prolong life as well as reduce the risk for completed suicide. Colleagues often wonder, given how busy clinicians are in their day-to-day service, how feasible it is actually to achieve full-blown symptomatic remission. Again, there is good data on this point. In primary care settings, for example, where most older adults receive treatment for depression if they receive it at all, using what are called collaborative care models, response is achieved with first-line treatments in about 50% of patients and remission in about 30%. But the overall rates of response and remission can be substantially increased with, for example, the further use of add-on strategies, augmentation strategies, such as adding a second medication or switching classes of medication or through the combination of medication and depression-specific counseling or psychotherapy. And as my colleagues point out, there are frequently medical or environmental factors that can represent barriers to full response and remission, but where partial response may still occur. I find it very helpful, if not indeed essential, to engage family caregivers in discussions about treatment to optimize treatment adherence and to help with environmental and psychosocial stressors. Also, in the spirit of team-based care, I will frequently consult colleagues in social work to help connect my patients with needed social resources in the community. So, to summarize the key points, we're talking about the fact that the goal of treating depression in older adults should include remission of symptoms, as well as restoration of a sense of well-being and ability to function in major social and familial roles. This is what truly matters to patients and to those who love them and give them care. But getting well is not enough. It's staying well that counts because of the high propensity of depression in old age to follow a relapsing and recurrent course. As we'll talk about in subsequent video chats as part of this lecture series, you will find that I emphasize that the dose of medication that gets you well is also the dose that keeps you well. Corollary to this is that if a second agent is needed in addition to the first to bring about remission, it should be continued as well to prevent relapse and recurrence. Thank you.